I'll get started and people can join while I'm talking. I introduce myself. I'm Sarah Green and I'm the Executive Officer of the Health Services Research Association of Australia and New Zealand. The aim of the association is to promote networking, education and training and build capacity in health services research in Australia and New Zealand. We aim to run these webinars at least once a month. The webinars are free to everybody, but we do give priority to association members if they start to fill up. And we would encourage everybody who's called in today to have a look at our website and think about joining the association, as we do rely on membership fees for most of our funding. And just to let you know, our next webinar is being held on the 19th of October and is being presented by Professor Judith Smith from the University of Birmingham, and she's going to be talking about developing primary care that is fit for future. Other things that the association gets up to, we run a couple of other activities throughout the year, and our next big event is our AGM and Symposium, which is being held at the National Press Club in Canberra on the 1st of December. And we'll be launching a specially commissioned report at that event into the state and potential of health services research in Australia and New Zealand. And in 2017, we have our biennial Health Services and Policy Research Conference, and that's being held on the Gold Coast on the 1st to the 3rd of November. And the theme that year is Shifting Priorities, Balancing Acute and Primary Care Services. We also run a number of awards each year to highlight the best and most impactful health services research, and we have a mentoring scheme that we run for emerging researchers. And probably all of you have seen that we run a regular bulletin of HSR news events and career opportunities. Suzanne's going to chair today's presentation. Suzanne is from Curtin University and she's a member of our executive committee. Just a couple of housekeeping issues. You should be able to see and hear everything that's going on the screen, but we can't see or hear you. But you can chat using the chat button at the bottom of the screen. So if you've got any comments or problems, let us know that way. And any questions that you'd like to put to the speakers, there's a Q&A button at the bottom of the screen and you can type your questions in there. And Suzanne and I will keep an eye on those and we'll relay them to the presenters at the end of their speeches. And I think Adam and Robyn intend to talk together for about 45 minutes this morning, and then we've allowed about 30 minutes for Q&A. So please, as many questions as you want, type them in. And we're recording the webinar this morning, so the video and the slides will be available on our website in about 1 or 2 days, and they'll be sent out to everybody who registered for the event as well. And I'll hand over to Suzanne.
Thanks, Sarah, that's great. Welcome everyone to our webinar series. I'm really excited to be sharing another interesting and really relevant webinar today. And before we begin, I would like to acknowledge the traditional custodians of our lands and respect our elders past and present. So moving on to the seminar, we're really lucky to have two high-profile presenters today, and these include Professor Adam Elshug and Dr. Robyn Lindner. They'll be presenting work on the Choosing Wisely campaign. This is an initiative that focuses on improving quality and efficiency across our healthcare sector. Robyn is a client and relationships manager at NPS Medicine Wise, and part of Robyn's role involves the implementation of the Choosing Wisely initiative. Adam is a professor of health policy, a HCF Research Foundation Professorial Research Fellow, and co-director of the Menzies Centre for Health Policy at the University of Sydney. Adam's got a number of extensive roles, far too long a list for me to read through, but I would direct you to his bio for the full list. But for today, the most important role is that of Chief Investigator within the Choosing Wisely Healthcare Collaborative. So both Robyn and Adam have extensive experience of the initiative and are well placed to deliver our seminar today. As Sarah noted, we've got 45 minutes for presentations, and I think that Robyn and Adam are going to do a duo act and switch seats partway through. We've got plenty of time for questions, and I know that our speakers are really keen for you to ask them some good questions and to really grill them on the work that they're doing. So if you want to post questions as we go, then Sarah and I will field those at the end of the session and ask the presenters the questions on your behalf. So that's enough from me. I'd just like to hand over to our speakers, and I think the first up is Dr. Robyn Lindner. Thank you.
Thanks, Suzanne, and thank you, Sarah, and thank you for the opportunity to talk to you all today. So, as Suzanne mentioned, Adam and I are doing a bit of a tag team today, and what I'm going to be doing is really setting the scene for choosing wisely, and particularly choosing wisely in Australia, and how we got to where we are and what our priorities are at the moment. And then I'll hand over to Adam, who can talk much more particularly from a research perspective around choosing wisely and low value care. So I wanted to start with this quote that I put up, and this is a quote by Daniel Wolfson, who I kind of consider as really the godfather of choosing wisely, and he was very much the brains behind the launch of the inaugural Choosing Wisely initiative in the US. And so this concept of wise management of healthcare resources being a core tenet of medical professionalism is really the theme that underpins Choosing Wisely, and it was really the driver for the original initiation and conceptualisation of Choosing Wisely. I am making an assumption today that most people are reasonably familiar with the initiative, so I apologise if I don't go into a huge amount of detail. But just as a bit of background, Choosing Wisely launched in the US in 2012. And at the time that it launched, there was really a current of anxiety, a culture and a mood of anxiety in the US about finite resources for the health system and how that was going to be managed. And at the time, an ethicist called Howard Brody published a paper where he challenged health professionals just by saying, will you as experts in your areas know where there is low value care that is currently being performed and being funded? And he really challenged people to take a leadership role and come forward and publish lists of things within their own area of specialty that should be questioned. And so the ABIM Foundation in the US with Daniel Wolfson really took that challenge on, and they started working with medical colleges in the US to develop lists and publish lists of things within different areas of medical specialty that should be questioned. And that's how Choosing Wisely in the US was born. From an Australian perspective, we've been doing some work in terms of understanding our situation, and as you would all be aware, we have a problem too in terms of over-testing and inappropriate use of finite healthcare resources. Some of the data that I'm showing here has come from surveying health professionals in Australia, and it's reassuring to know that doctors and specialists, GPs and specialists agree that we do have a problem with over-testing, and they also see that they do have a responsibility to help reduce over-testing. Consumer demand is frequently cited by clinicians as being one of the drivers for unnecessary testing. And there's a lot of discussion around the amount of time that clinicians spend discouraging patients from requesting things that the doctors think that aren't actually required. In particular, we've been interested in some of the drivers of inappropriate care, and in some of our survey work, and these results where we've surveyed about 500 specialists and also GPs, and we've asked them what are some of the main reasons why you might end up requesting a test or treatment or procedure that isn't actually necessary. And we've gathered a whole lot of data, and I'm not going to talk to all the data now. I just particularly want to focus on the first point that's highlighted here, and that is around patient expectations. And you'll see that GPs say that around 60% of the time when they do something that's unnecessary, it's because they believe that the patient has an expectation, that is what they want. And similarly, specialists are saying that around 44% of the time, that is one of the reasons that they might order something that they understand and believe is unnecessary for the patient. Interestingly though, when we survey consumers, and we recently, MPS Medicine Wise recently did some surveys with around over 2,000 consumers, and we asked the question of people who had recently had a medical test, the reasons why they have medical tests. And in that situation, around 80% of people said they did it because the healthcare provider recommended that they should have it. And only 16% of people said that they had a test because they had requested it and they had asked for it. And so you can see there's a disconnect there in terms of what doctors are perceiving is happening and what patients are demanding versus what consumers perceive is happening. And it really highlights a need for better communication between doctors and patients about what people's expectations are around healthcare. And that's a really important point because it's central to the whole theme around choosing wisely. So Choosing Wisely launched in Australia in April 2015, so we're not much more than a year old. And since launching, we've now got over 20 health professional organisations have signed up to the initiative and have published lists of things that you should question. And that releasing and publishing of lists of things you should question is ongoing. We, in the next month or so, will be releasing another suite of lists of recommendations of things that you should question. So I encourage you to stay tuned for that and look out for it. And I would really encourage you to go and have a look at the website if you haven't already done so. The website highlights the recommendations that are published by all the different colleges and also highlights the evidence that supports those recommendations. And that's a really important component of Choosing Wisely, is that all the recommendations are evidence-based and that evidence is readily available. We're really pleased to be able to say that 75% of medical colleges in Australia have now signed up to the initiative. So it really highlights the level of engagement in the Australian medical community around the campaign. So I talked before about the importance of having good conversations between doctors and patients, and at its core, that is what Choosing Wisely is about. It's seeking to affect a culture shift by encouraging conversations around appropriate healthcare and challenging the notion that more is always better when it comes to healthcare. And we hear that language a lot around, you know, it's important to have conversations, but it's really important in healthcare because actually good communication is really central to the delivery of quality healthcare. So it very much aligns with that, that concept. The lists that are generated by the colleges and associations of things to question is the basis and is a starting point for the health professional community to start having a conversation about appropriate healthcare. So often, in some instances, that's the first time that colleges might have been actively having conversations with their members about things that are happening within their area of remit that might not always be necessary. So the way that the colleges go about developing those lists is really important, and we really encourage them to not just set up a small group and do that in isolation, but to actively seek ways to engage with their membership around providing feedback and input into that process. An important component around Choosing Wisely is that it's health profession led, and that's one of the factors that really differentiates it from some other quality improvement initiatives, which might be perceived as being sort of a top-down imposed approach. The idea with Choosing Wisely is that it's led by the health professionals and really owned by them. So they have a strong sense of ownership and an interest in being engaged in the messages that are being developed as part of the initiative. And at its core, it's about improving outcomes for the general public. So patients are very much at the centre of this in terms of trying to reduce people's exposure to harm by having tests, treatments and procedures for which there's not a good evidence base in terms of their value. The other important thing to flag with the recommendations, which are all things that you should all use the language around do not do, the language is really intentional in that they're all things you should question. So it's not saying that all of these recommendations have no clinical value. It's about the fact that in some people they might have, there might be benefit, but understanding who's going to benefit from some of these interventions requires, again, a good conversation between a doctor and the patient around whether this is the most appropriate thing for them. So it's really highlighting the fact that medicine is rarely black and white. There's a whole lot of grey in the middle, and navigating that grey requires good dialogue between general public and doctors. The Choosing Wisely initiative, as I said, originated in the US, and there's now significant international interest. There's around 17, I think there's about 17 countries now at various stages of launching or developing Choosing Wisely initiatives. Some of the big and most active campaigns are in the US, Canada, the Netherlands, but recently the UK launched an initiative, Israel and Brazil, just to name a few. So it's really captured the imagination of clinicians around the world, and there's now a good Choosing Wisely international community with which we can interact and actually learn from one another, which is fantastic. The key elements of Choosing Wisely, as I've talked about, are the recommendations from the colleges. And so I've just, on this slide, just showing a couple, some examples of one of those. So on the left, I've got one from the College of Emergency Medicine. And there'll be a statement, and then there'll be the contextualisation that goes with those recommendations. And then published at the back of the lists are the evidence and also the methods that the colleges have used to develop those lists. So that it's really important that there's that level of transparency around the information that's being produced. To support promotion of those recommendations, we've developed a resource to promote better conversations between doctors and their patients. And this is a resource which I've got on the right-hand side of this slide, which lists 5 questions to ask your doctor. And this is very much the consumer sort of angle for Choosing Wisely that we're trying to promote. And so the idea there is that independent of any kind of medical condition, these are some questions that it's really appropriate for people to be asking their doctor when they go to see them, so that people are making informed decisions about the healthcare they're receiving and are informed about what the risks are and what the alternatives are for them. So with this resource really forms part of the core consumer sort of promotion that we are engaging with as part of Choosing Wisely. Key and really, I guess, sort of non-negotiable sort of elements to Choosing Wisely are, just going over this, is the fact that it is health profession led. That's really important. That has been critical to getting health professionals on board, and it's really important that we adhere to that going forward in terms of thinking about ways that we implement this and we don't lose sight of that being a critical success factor for the initiative. And again, that it is about improving outcomes for patients. That's absolutely central to both health professional and also consumer engagement in the initiative. The recommendations absolutely need to be evidence-based, and we really encourage, where there's debate around any of the recommendations, for that conversation to be focused around people coming up with counter evidence, so that at the end of the day, it's always focused on what does the evidence say is most appropriate. Similarly, as we've talked about, transparency of process is really important. And multidisciplinary, we really encourage having all members of the healthcare, health professional network involved, because it's recognising that healthcare is really delivered as a system, and we need to have all people buying into the notion of challenging more is always better when it comes to healthcare. And then finally, just reinforcing the idea that these recommendations are not absolutes, they're not black and white, they're things that should be questioned and need to be part of an informed conversation between a consumer and their doctor. So the US campaign launched in 2012, and so we're now at a point where there's been a lot of debate about how effective that campaign has been. And I think there are different schools of thought around whether it's been successful or not, depending on how you perceive the Choosing Wisely initiative. From an engagement perspective, they've got a large number of colleges on board now. There's over 70, and they have over 400 recommendations that have come out of that. And they would be the first to admit that they don't need any more recommendations. There needs to be a focus on implementation. There's been a significant amount of media interest, and the fact that it's become a social and international movement is really pays tribute to the fact that the whole design of the Choosing Wisely campaign in the US has really captured people's attention. Where the criticism has come from is people, I guess, looking at whether they think there's been significant impact in terms of utilisation of items, and also, I guess, the manner in which some of the colleges may have bought into the campaign. And that's where we've had an opportunity to really learn from what's gone before. And so some of the things that we've done there are, and I'll talk more about our approaches around implementation, but I think some of the things that are important to know are, when the Choosing Wisely campaign launched in the US, they had no idea whether it would be successful or not. So they really hadn't thought of a strategy beyond development of the lists. It was really a case of, let's put out these lists and see whether we get any traction. And they got a lot of traction from the medical community, and also from consumer organisations, and generally from the media. So from that perspective, it's been very effective. They would be the first to acknowledge that if you want to get impact in terms of changes in utilisation of these items, you need to have strategies around implementation to support that. From a college engagement and trying to make sure that people develop recommendations that are prioritising areas where there's low value care. We've learned a lot from that, from the process in the US, and we've had a big focus in Australia on encouraging colleges to stick to their own area of remit and not so much point at other areas of disciplines, but really reflect on their own backyard, and really encouraging them to be very transparent about what evidence supports their recommendations, and encouraging cross-college conversations because some of the issues where we have inappropriate care is because there's different schools of thought between different colleges as to what's actually appropriate or not. So really encouraging those conversations is really important. The advantage that we have in Australia with our Choosing Wisely campaign is that by trailing the US and Canada, which launched in 2014, we get an opportunity to learn from them in terms of some of the things that have worked and some of the things that haven't. And so I'm just going to talk a little bit about some of the work that's been happening in Canada around implementation of their Choosing Wisely recommendations. So this slide talks about an implementation spectrum, which really talks about the different, I guess, the spectrum of different types of implementation activities that you can undertake. And on the left-hand side, we're talking about activities that focus on engagement and education. And these are activities where the individual can have a strong role as being the change unit. And it's very much about engaging with people to participate in those activities. And at the other end of the spectrum, you've got the hard coding, which is where, much more about, hardwiring things in electronic medical record systems and policy changes. And so we're encouraging people to participate anywhere along this spectrum, but acknowledging that if this is to be health profession led, it's really important that we're making sure that any initiatives are not just hardwired. It is about engaging people at an individual level to participate. In Canada, North York General Hospital, they have implemented a multifaceted campaign that spans all elements of that implementation spectrum. So through to engaging staff and patients through different initiatives, right through to hardwiring some of these recommendations into their computer systems. And they've been very effective in terms of showing changes in utilisation in a number of test areas. These results show that they were able to show about a 40% decline in some of the testing that was being done in emergency departments as a result of those interventions that were flagged earlier. And they've been subsequently able to sustain that change in utilisation over time. So it's a great sort of small local case study of showing how multifaceted interventions can be really effective in terms of reducing unnecessary care in targeted areas. And we've taken this model and are looking at how we can implement similar approaches in Australia. So a little bit about what we're doing. So when we first set up Choosing Wisely in Australia, we consulted quite broadly with a number, particularly medical colleges, and asked them what did they want Choosing Wisely in Australia to look like. And overwhelmingly, it was very important for them that it wasn't just about putting out a campaign where we're putting out lists of recommendations, but that there is a strategy about how we implement and evaluate the impact of the campaign. And so to support that, we need to have multifaceted approaches to address that. So this table talks about some of the different strategies you can apply, and it's based on a paper that has been published as part of the International Choosing Wisely working group, of which both myself and Adam are a part. And it talks about the different areas that we want to have a focus on and some of the activities that are recommended in terms of having an impact. And I'll talk through some of these now. So for example, in terms of changing clinician attitudes, some of the work that we're doing now with medical colleges is, now that they've published their lists, is saying, okay, well, what can you do within your area of remit to embed these recommendations so they become almost business as usual? Because that's when we will have achieved success for Choosing Wisely, is when consideration of inappropriate care and education around some of these inappropriate items becomes standard practice. And so some of the colleges have developed things like clinical decision rules and apps to support their recommendations. Others are looking at how they can embed the recommendations into education and exam and curriculum for their members. So that's an example of some of the ways that some of the colleges are looking at how they can hardwire some of the recommendations. From a consumer engagement perspective, we're doing a lot of work around public messaging, media campaigns, and also consumer partnerships with key groups. The idea of, one message, many voices, and how can we amplify getting this message out there by having very targeted consumer partnerships as we go. And then we're looking at how we can embed in clinical practice, and I'll talk a little bit about that now in terms of some of the pilot site and national programs that we're doing. And then importantly, over time, we need to look at how these recommendations are really having an impact on policy in the health space. And I think that's an area that could be of interest to this group in terms of really thinking about how you measure the impacts of the initiative, what influences it has had on changing health policy. So one of the ways that we're implementing these recommendations is leveraging the reach of NPS Medicine Wise. So NPS Medicine Wise is the organisation that I work for, and NPS is facilitating the Choosing Wisely initiative. So that means that we're working closely with the colleges to implement the initiative, but we're also leveraging our kind of business as usual activities, which include national programs, primarily targeting primary care, but we also have reach into hospitals. And so we're looking at, wherever possible, integrating Choosing Wisely messaging into those programs. As an example, we're about to launch a national program that will reach in face-to-face educational visits around 7,000 or 8,000 GPs through academic detailing. GPs will receive feedback on some of their requesting behaviour around imaging for knee and ankle. We're developing online CPD activities for them to participate in, and then also developing patient resources to support better conversations between doctors and their patients. And we've recently done similar programs of this nature in areas such as antibiotics and proton pump inhibitors as an example. And the benefit of this too is we'll be able to evaluate those programs. So we'll be able to look at what impact we've had both in terms of both qualitatively and quantitatively. So we'll look at changes in utilisation of some of the key items that we're looking at, but also changes in knowledge and attitudes and awareness from health professionals around those particular items as well. And we'll be able to report on those over time. We're also setting up pilot sites, and I really encourage you to think about in your networks whether this is appropriate for local health districts and PHNs that you might be involved with, and hospitals, whether it's appropriate to join up. The benefit of what we're doing with the pilot sites is encouraging people to sign up, and they're committing to participating in doing something really in a quality improvement space, and that can be something tiny or it can be something quite big. It's really based on what resources that particular organisation has at their disposal, but they're committing to doing something that supports Choosing Wisely objectives over a 12-month period and then reporting on it. And so this is an opportunity for us to see what works and what doesn't. And as part of these pilot sites, what we're doing is creating a network, a learning network where people can come together and share learning so that hopefully the next person or organisation that wants to go and do something, they can learn from what those have done before them. So it's very much a kind of a learning collaborative style. Gold Coast Hospital and Health Service have been doing some fantastic work. So they're one of our pilot sites, and they're doing some fantastic work in the pathology space. And they're using a data dashboard really to inform decisions around where they have their focus. So they've pulled out data and then they've shown it to their clinicians, and the clinicians are looking at that data and thinking, okay, well that's fine, but that doesn't look right. That looks like we're doing something that might be inappropriate. They're then going in and unpacking what the drivers are for that inappropriate care and implementing initiatives to actually affect a change, and then they're measuring that change. And so they're doing it in a small sort of iterative process, but they're starting to get some really nice data in terms of showing changes in utilisation without any adverse consequences for consumers. So that'll be something that we're really excited about reporting on over time as it goes forward. We're also working with a number of other sites who are just sort of getting started in terms of working in different areas, but these include the Royal Adelaide Hospital, who are doing some work on imaging, Sir Charles Gardner Hospital in Perth, who are doing some work around quality use of medicines, and then both Austin and Monash Health, who haven't yet formally signed up as pilot sites, but they're doing some fantastic work. Particularly Austin Health are working on registrar training, and Monash Health are doing some work, really multifaceted approaches, but including ways that they can particularly engage with patients around Choosing Wisely recommendations. So it's very much a watch this space, and we're hoping to be able to report back as we go forward on some of the outcomes from those pilot sites. Very quickly, from a consumer perspective, we're looking at a range of different approaches to really get the message out there and empower consumers around having better conversations with their doctors. The part of this is media campaigns, and hopefully some of you have seen at different points in time stories around the Choosing Wisely initiative. We've developed patient resources, so some of the recommendations have patient resources attached to them, and we're very focused on identifying existing resources rather than creating new ones if we don't have to. It's all about efficient use of resources at that level as well. So yeah, we're trying to be very efficient, and we're very happy to link through to other resources as it's appropriate. We're working closely with Consumer Health Forum in terms of our strategy around patient engagement, and we've got a number of partnerships with groups like Health Direct, for example, that drive and embed links around Choosing Wisely in their website to refer people to us, to our website. We've to contextualise the idea of asking questions of your doctor. We've done some great work with Julie McCrossan, where we've gone out and developed some Vox Pops that have people talking about what are some of the challenges in terms of talking to your doctor and asking questions. And these have been really well received through social media and on the website. And I really encourage you to go and have a look at the website and look at those videos, because it's a great way of kind of humanising what's a pretty dry topic and getting people's perceptions about what some of the challenges are around engaging in conversations with your doctor. And then finally, one of the last areas we're looking at is around getting local stories. And so we've been working with some of the local health districts who have been promoting the 5 questions to ask your doctor with their community members, and getting feedback from them in terms of how that has had an impact in terms of being an enabler for them to have better conversations with their doctor and also better health outcomes. And as we build those stories, again, we're looking at how we can publish them, because we think they're a great enabler for people to get involved in the initiative. And then finally, just in terms of commenting on, are we having any impact in the campaign? Obviously, from an Australian perspective, it's very young. We've really only been going a bit over a year, but we've been doing some surveys with both consumers and health professionals. And we were able to show in our consumer survey at the end of last year that in surveying the general public, those people who were aware of Choosing Wisely, and that's the aware group shown on this slide, they were much more likely to agree with the notion that some tests can produce misleading results and unnecessary treatments, and agreeing that having unnecessary care can be harmful. So that was about 55% compared to around 35% for the general population. So we're seeing some evidence that knowledge of Choosing Wisely is really changing people's attitudes around healthcare. And on that note, I'm going to swap over to Adam.
Hi everyone, welcome to the webinar. I would like to take an opportunity actually to thank Robyn for the work that she's doing on Choosing Wisely. She really has been a power broker behind the scenes. She's laughing because she's modest, but really she's been facilitating this with great panache, and I think its success is really down to her in lots of ways, and the great team she has there at Peers Medicine Wise. So I'm going to talk a little bit about Choosing Wisely and how it fits into the, I guess, the larger scenery, both in terms of other campaigns that are happening that are complementing each other, and also from an academics researcher's perspective in some of the things that we are interested in from an evaluation point of view, and that really I'm calling on those who are present today in this webinar to assist us with, because there's a lot of work that needs to be done. So we want a call to arms of sorts. So if you're going to read a couple of papers that really background some of this work, one comes from Dr. Sasha Bhatia out of Toronto. Sasha is one of the Choosing Wisely International Planning Committee core personnel, and we wrote this paper just trying to sort of plot out a framework that could be used to assess the implementation strategies and the effectiveness of them. The second paper is from Dan Morgan. Dan is in Baltimore in the US. And again, this was a paper that we worked on about setting a research agenda for medical overuse. And I'm actually going to use this paper from Dan to point out some of the areas where there is work underway, including some of the work we're doing here in Australia, but also where we think there's a lot more that could be done in the area. So there's a lot of text here. I'm not asking you to read through it all. In fact, I'm going to just draw attention to some individual dot points here. The first is measuring the frequency of overuse. I've been interested in this area for well, about a decade or more now, and I watched the Choosing Wisely campaign develop with great interest, and it actually started while I was in the United States for a period. And now that there's over a dozen countries involved, I've always found it very curious that we have this very proactive and positive movement led by the clinical community about services that we think are being overused in some circumstances, and yet we have very little baseline data to know the scope or the scale of the problem. So just the measurement of this problem is really quite lacking, particularly outside of the United States. So we're looking to remedy that. Together with Sally Pearson, we're leading a team who are undertaking a very large measurement program. In fact, some of them are sitting behind the glass behind me. If you see them doing star jumps, that's who they are. So we're interested in looking at measuring baseline episodes of prevalence of low-value care, patterns of use, costs, characteristics, predictability. And we're also doing a collaboration with the Choosing Wisely International team to do some cross-country comparisons. It's probably the largest measurement program in the world that we have underway here now, and we think it's going to produce some very exciting results, particularly because we're measuring from all of the various payers' perspectives. And I'm just going to show you some of the very preliminary results here. So all of the services you can see on the left-hand side here are Choosing Wisely recommendations, not necessarily from Australia, but from any Choosing Wisely list around the world. Every dot that you see is a hospital, and the little black lines, the vertical black lines, are the state averages for the hospitals. And the further that those dots sit to the right of this chart, that means that that's the higher proportion of procedures that are performed in that hospital actually represent low-value care as measured at the individual patient level. So this is really world first in terms of looking at this breadth of information. And you can see that there's quite a lot of variance between hospitals. We're not necessarily calling that out too much at the moment, but we certainly think that it's hypothesis generating. And as a lead indicator, it allows us to go in and look at some of the characteristics that might be leading to that variation. You can see that for some of those services, some hospitals are performing 80% of those procedures are considered low value according to a Choosing Wisely recommendation, whereas some, sitting down the left-hand side, some of those hospitals are performing 0% of those low value care procedures. So more results are going to be coming like this towards the end of this year and into early next year, as I said, across public hospitals, MBS, PBS and private health insurance claims databases as well. So the next little area of interest that we think is very interesting is the drivers of overuse. Robyn showed you this chart earlier where MPS Medicine-Wise surveyed GPs and specialists around what they think are the reasons driving unnecessary tests and treatments. This is highly valid as perceived from a doctor's perspective, but also, as we saw earlier, it doesn't quite match up with what the patients are perceiving. Doctors are suggesting that patients are asking for things, whereas patients are saying that doctors are suggesting things. So it's a bit of a chicken and egg problem here. And in fact, there's a much greater context for the drivers, the factors causing overuse. And if you just look across this list, both intrinsic and extrinsic at the patient and provider level, just on this one slide, every researcher, health services researcher in Australia could be kept busy for the rest of their careers just investigating any one of these dot points. But we're interested in what the interaction effect is between these drivers, whether there's a hierarchy, which ones are amenable to remedy, which ones are not, or more difficult to remedy. And that's some of the work that is actually underway now with some fairly exciting results. As well, when we think about the impact of low-value care, we're also interested in the impact of overuse in terms of both the physical and psychological harm. I've mentioned the measurement work that we're doing here in Australia and that's occurring elsewhere in the world. Most of that measurement work is actually interested in measuring just the index low-value care event. That is, did a test occur, did a treatment occur, yes or no, and we can measure the costs and the characteristics of that. But few groups have actually gone and looked at the cascade effects or flow-on effects of those individual tests. This is a good example out of the United States, where Canzario looked at unnecessary admissions for syncope and then looked at all the flow-on effects of that and found that actually that there is a strong cascade impact of those unnecessary admissions. And we know that the same is true for other things like PSA testing for prostate cancer and the like. You can measure the index PSA test, but actually what they lead on to and the flow-on consequences can be much more significant, both from a financial point of view, but also from a patient impact point of view, both physical and psychological. And much of the work that's occurring in the overdiagnosis area, I think, is really starting to tackle this problem in a comprehensive way. And then, of course, we're interested in strategies to mitigate overuse. So, as Robyn alluded to in her presentation, we need baseline measurements, but we need to understand the impact of choosing wisely initiatives on clinical practice and patient outcomes. And that is, as a long-term goal, are we actually reducing utilisation of so-called low-value practices? And this, again, cuts to an interesting point in this whole debate, whether or not choosing wisely should be seen as merely a campaign, or whether it's an actual intervention, or whether it's one or both of those things. A paper that came out from Rosenberg in JAMA Internal Medicine back in 2015 was really the first paper that claimed to measure the impact of choosing wisely as a campaign in the United States. And they looked at utilisation pre and post choosing wisely campaign across 7 services, and they found that for a couple they decreased, for a couple they increased, and that for 3 there was really no change at all. And this actually got a lot of press in the US and internationally, and people said, well, what sort of effect is choosing wisely having? It's ineffective, it's not really working. I disagree with that perspective because I'm of the opinion that, yes, choosing wisely is a campaign more than an intervention in and of itself. And that, for those who are interested, those are the actual individual charts for some of those services. But what those same authors pointed out is that actually there is no single intervention, whether or not you consider choosing wisely an intervention, that is going to be effective on its own. And in fact, there need to be additional elements to any kind of interventional undertaking, from all of the things that you can see highlighted there in blue, all of the things that MPS Medicine Wise are undertaking, and more. And then if you compare that to where choosing wisely was explicitly thought of as only part of an intervention, not an intervention in itself. This is work conducted by Aaron Schwartz and co-workers at Boston, where they're really interested in the pioneer accountable care organisations that are starting to proliferate in the United States. And they did quite an elegant piece of work looking at the ACO pre-contract period and looking at the trends of use of low-value services. We found that they're actually similar for the ACO and control group providers pre-ACO contract. And then after the first year of the ACO contracts, they saw that that low-value care was associated with a 1.9% differential reduction in the ACO group as the intervention, and that equated to a 4.5% differential reduction in spending on low-value services. And keeping in mind that's just 31 low-value services. So I would say that looking at choosing wisely through that lens as part of the broader intervention, it's actually quite effective. If you think about what a 4.5% reduction in Medicare spending in Australia, for example, would equate to over just 31 low-value services, I think that is incredibly significant. And again, this is the same study by Schwartz and now this is taken from their paper. You can also see that the low-value services by clinical category all showed reductions. So it didn't happen just in one area, it was actually across the board, which was also, I think, quite instructive. So jumping to Australia, this was an example. This was work that my group did, analysis that we did and presented to the Senate Select Committee on Health last year. A little bit of history here. The former Labor government was involved in a MBS review type initiative that I was involved in. And vitamin D testing, pathology testing, was one of the services that came under review. And in November of 2014, there were changes made to the Medicare benefit schedule item descriptors, which sought to just recommend that the test be restricted to certain groups, patient groups that are of higher risk. It implemented an interval limit on the number of tests, and overnight it resulted in a 40+% reduction in testing. Same happened for B12 and same happened for folate, and we presented this work to the Senate Select Committee and found that from the preliminary analysis, if these reductions are maintained, that over forward estimates of 5 years, it will result in about a $650 million saving to Medicare from just 3 tests, with fairly minor changes being made to the item descriptors. And I think the important thing here is that no one is suggesting that these tests are ineffective. It's just suggesting that actually the curve, you know, the utilisation curve had probably gone a little bit higher than groups had anticipated was clinically appropriate, and we just want to bring that down a little bit, and that has happened to some effect. And interestingly, work that's happening in Canada and various provinces there has shown that the same has occurred. In fact, some greater falls have occurred in some areas in Canada. And then from someone who's interested in health policy, we also know that there is no single magic bullet to any of these reductions, and we draw on C-section rates as an exemplar case study here. All of the countries that you can see listed there, Italy, Belgium, France, England, Korea, have all seen reductions in their C-section rates. But they've achieved that through various means. It really just points to the fact that context is everything, and you need to be aware of what may or may not work within the local context. And again, that speaks heavily to the work that's happening in the Choosing Wisely campaign. As Robyn indicated, we're very interested in understanding what happens in these pilot sites throughout Australia that contributes to success and failures, and how that can be learned around the country and beyond. Just a very brief plug here. Later this year or early next year, we have a series of papers coming out in the Lancet dedicated to this particular topic, where we're going to be looking at the evidence for overuse around the world, as well as underuse, the drivers, and also looking at some of the levers, and that was the paper that I led. It's very interesting that there are lots and lots of levers out there that theoretically could be reducing low value care. Interestingly, there's actually very limited in terms of the evidence base for those levers, even though many of them are being implemented. And that's either because the evaluation work isn't being done, and that's certainly the case in some areas, but often it's actually because the evaluation work is occurring within policy areas, so health departments, where they are not necessarily publishing peer-reviewed literature. So in fact, the evidence base behind some of these leverage points is actually quite low. And again, I think it's a bit of a call to arm for both policy and academic and clinical communities to try and improve our evaluation of where some of these leverage points are effective and where they're ineffective, and why. And then really, I just wanted to finish on a broader perspective. I'm involved in numerous initiatives, all trying to get at this problem of low value care, including Choosing Wisely. The RACP Evolve Sister Initiative, as well as Cancer Australia Statements, which is a sister initiative, are all interested in developing these evidence-based lists of low value care. But of course, neither of those programs are an island. They're actually they're occurring in conjunction with, sometimes tightly linked with, sometimes independent of, but certainly involved on a broader scale with the Australian Commission on Social and Quality Healthcare's Atlas of Healthcare Variation, the MBS review, which I sit on. Interestingly, the Choosing Wisely recommendations are feeding directly into the clinical committees of the MBS review. So they're directly impacting on some of the services that we're interested in looking at. Similarly, we're using the Atlas of Healthcare Variation to see whether or not there are problems in variable use around the country. There's very interesting work happening at the private health insurance level. Not only are they interested in this problem for their own members, but they're starting to now combine efforts like the recent initiative between Medibank Private and the Royal Australian College of Surgeons, where they're sharing data, trying to get at the problem of variation in practice and pricing. The Medical Homes Initiative is certainly very interesting in terms of how we can start to move away from a volume-based system to a value-based system, thinking about integrated care and alternative payment models. As Robyn indicated, we have the Choosing Wisely pilot sites, but in fact, there are many hospitals and health districts around the country that have for a long time been implementing their own safety and quality initiatives that haven't necessarily fallen directly under a Choosing Wisely banner, may not be formally associated with the Choosing Wisely campaign, but I think the interventions are very, very well aligned to the goals of the Choosing Wisely initiatives. And many of them are being driven by clinicians who are very proactive and have a lot of clinical expertise, but could really do with some assistance from the research and evaluation community to try and help them either design interventions or evaluation efforts around those activities. And above and beyond that, I think there's a real opportunity in Australia for us to join up these efforts so we can learn from one another as to where things are working, where they're not working, and why. So some compare and contrast. And then we have the media. I think the media is often thought of as a double-edged sword in this area, and it certainly can be, but I'd say that over the last 2 or 3 years, the mainstream media has certainly been much more proactive about trying to bring to the public consciousness this idea that that less is sometimes more. And that's also, I guess, mirroring some of the peer-reviewed literature, like the less is more in too much medicine, elements within B&J and JAMA internal medicine. So as someone who is of your ilk, a researcher, someone who's interested in policy, I think there's much more that we can do as a community to become engaged in this process, and be it developing grants or assisting with those on the ground who are implementing this work at the coalface, to get the interventions as robust and rigorous as we can, as well as the evaluations. So with that, I think we're going to stop and maybe hand over and go to question time. So we might bring Associate Professor Robinson back in and ask if she can facilitate some questions.
Thanks, Helen. That was excellent. Thanks, Robyn, also. It's great to see just that you're thinking around the research and evaluation quite early on in the patch, which I think is a really important thing. We have got a question actually from the floor, and I would encourage people who are online to post your questions. And we have a question, I think this one might be towards you, Robyn, and it's from Belinda O'Sullivan. So firstly, a really interesting overview. And the question is, do you have an idea what characteristics of doctors relate to prescribing or ordering unnecessary tests? So that was the first part of the question. And the second was, and whether this differs for doctors at a geographic level, e.g. rural versus metro regions.
Thanks, Suzanne. Look, that's a great question. Look, I think we can probably make some generalisations about doctors which may or may not be appropriate about who orders what. So as an example, I mean, I think, and I'm hoping I'm not going to offend any older or younger doctors, but often you get feedback from older doctors to say, oh, well, it's the junior doctors that order, X, Y, and Z because they don't know any better. And we have younger doctors sometimes saying, well, we do it because that's what we've been told by our superiors. And I think probably what's true is that you have some of that's true, but you also have a whole range of different variables in between. So I guess the short answer is I think it really is, I think we can make some generalisations like that, but I do really think that there is, it's going to be distinct for each individual in terms of what some of those contributing factors are. I mean, certainly things like medical litigation, those concerns, certainly going out and talking to people at conferences, the junior doctors seem much more concerned about that as a risk, which sometimes might contribute to their behaviour. Now, whether that's a real risk or a perceived risk is something else, but I certainly think that that is certainly influencing their behaviour. From a geographical perspective, I would probably default to some of the data from the Atlas of variation in terms of showing some of those distributions, and I think that's probably a work in progress in terms of understanding what some of the contributors are to some of that variation. So it's very complex, I guess. This is my summary at the end of the day.
And I'd just add, there was early work from the United States which did indicate that it was some of the younger doctors that were slightly over ordering, but a more recent paper has actually contradicted that and has gone the other way and suggested that it's some of the more senior doctors who are requesting more. So that's interesting that there's that difference, and I wonder whether or not there is some kind of intervention effect there as well, which might mean that junior doctors are also more amenable to change, potentially.
Yeah, the point has been posted from a SACS review that showed that paediatrics, it was older doctors who did more unnecessary testing. Yeah. And also some work I've been involved in with the medical home was just some of the older doctors just trying to get them involved and to be innovators and to change. I suppose it's all about behaviours, whether it's the younger end or the older end. And I suppose the question is, how do you work with those groups? And I wonder if you've got any thoughts on how you might work with the different groups to change that pattern of behaviour and to really engage them with something like choosing wisely.
Yeah, well, I think some of the tactics and some of the things we've looked at, as particularly organisations like MPS Medicine Wise, is sort of engaging some of the more experienced doctors, for example, in sort of train the trainer type concepts, where we're asking them to be the deliverers of evidence-based education about what's appropriate, and in doing so, they need to be engaging in the messaging that's around that. So that's sort of one approach that we would look at. From that perspective, but I think it requires, as we've been saying, multifaceted approaches. Yeah,
and also we did some interesting work in South Australia with the South Australian Clinical Senate, where we asked more established clinicians where they thought the low value care resided, and we also asked junior doctors And it was interesting, the older doctors felt that it was, you know, tests and treatments. Some of the junior doctors thought there's a lot of waste in administrative waste. So repeating tests that were unnecessary and a lot of the paperwork associated with care. So it was interesting from the different perspectives as well. Probably because they're doing more of the administrative work at the junior level, that they appreciated more waste in that area also.
I'd also add to that, I think this is where data is a very powerful thing in terms of getting buy-in from clinicians about what's inappropriate. So some of the feedback we've had from the work that's happening at Gold Coast Health was that initially some of the clinicians, when they were approached to be involved in that pathology program, said, oh, well, we're not aware of anything that's been done that's inappropriate. But then when they were provided the data, they were asked to interpret it and make recommendations, and then they were the ones that were coming back and saying, oh, hang on, actually that's not appropriate. So developing tools that actually allow people to buy into identifying what's inappropriate and involving them in the process of identifying solutions, I think is a very powerful model.
Thanks, that's great responses. I have another question from Jill Harvey, who I think if it's Jill Harvey, I know she's over in Adelaide. And her question is around choosing wisely sounds to be medically focused. How and to what extent are other professional groups involved? And is there a need for a more interdisciplinary approach? So just get your views on that.
Yeah, no, look, that's a great question. So Jill, we have, as I said, we've got about 75% of all the medical colleges on board, but we're actually really excited that we also have quite a broad representation of other health professionals. So the first Choosing Wisely initiative globally to have a pharmacy group on board. So the Society for Hospital Pharmacists are a member, as is the College of Nursing. We've got the Australian Physiotherapy Association is on board as well. So, and they're, I guess, some examples of we're sort of a broader church than just what we would consider as sort of the traditional medical colleges. And I think it's really important to have that multidisciplinary input, because as we've discussed before, you know, delivery of healthcare is a system, and there's, you know, so many contact points. And often, I think particularly nurses and pharmacists, a lot of data suggests that they're actually very good influencers too with consumers. Often they're the ones that provide a lot of feedback to consumers. So I think as well as identifying recommendations, they play a really important role in terms of facilitating implementation as well.
Thanks. Jill's got a second question, so I'll carry on with that if that's okay. It's around just whether or not choosing wise is any different, and if so, how and why, from the broader field of knowledge translation and implementation science. And so the point here is, isn't it all about encouraging and enabling more evidence-based clinical decision making? So the question being, is it any different than the work we've done, or the people who are doing around knowledge translation and implementation science?
Yeah, look, it's a great question. I would say it's not really any different. I think the difference is the model of rolling it out. So it's about engaging with, it's that sense of ownership and very much being health professional led. I think that is really the differentiator. So it's giving that sense of ownership. It's not, you know, NPS going out and saying, this is what you need to do. It's the College of GPs, as an example, identifying a list of what they've identified as recommendations of low value care. So there's that real sense of ownership from the health professionals around where they want to focus their efforts.
And I think that speaks somewhat to the genesis of the Choosing Wisely campaign in the United States. It actually goes back as far as 2009, where there were 2 or 3 individual specialty societies or colleges who actually were very proactive and came forward suggesting that there is a need for this work and there is a need for it to be clinician driven, and that they were going to develop their own lists, their own top 5 lists. And then the ABAM Foundation came on board and Consumer Reports to actually pick up and carry it further. So really, truly, it was very, very grassroots driven by the clinical community. But beyond that, I agree with Robyn. Once the lists are developed, then we're back into the world of evidence-based, 30 years of evidence-based medicine. Yeah.
Thank you. We've got a couple more questions, so we'll carry on. We've got one here from Kesley Chalmers, and it's first, thanks for the presentation. And then a question, I think it's directed to you, Robyn. One of the criticisms on the US Choosing Wisely was that some medical colleagues chose recommendations that were outside their speciality or had no impact on their income. And just what were your thoughts on this? And was this an issue considered when forming the Australian Choosing Wisely lists? So it could be for any of you, although your name's on there, Robyn, so it could be for either of you, I'm sure.
Yeah, look, again, another great question. Yes, we were very aware that was one of the criticisms. And So we were very mindful of that when we were engaging with the colleges. The feedback we gave them were exactly those criticisms and really encouraging them to focus on their own backyard, because at the end of the day, they own the recommendations. So they have to stand up to any scrutiny that, and you know, I guess any kind of discrediting that happens with their recommendations. So we've worked hard to encourage them to focus on their own areas. Of course, there are some challenges there where that we still see some evidence of people pointing at other disciplines, and sometimes it's challenging where certain procedures happen across a range of different kind of sectors as well. But we very much encourage the colleges to reflect on that when they're developing their lists. I will say though that one of the critical success factors for choosing wisely is the fact that the lists are owned by the colleges. So we can provide guidance, but we resist from being absolutely instructive about what should be on those lists, because it's really important that they have that sense of ownership. So it's a bit of a balance.
Okay, thank you. We've got another question here from Harriet Hiscock, and it's in terms of evaluating impact. So her point is this is perhaps easier in inpatient and ED settings where we've got national data sets. And the question really is around how do we measure impact in outpatient care, both public and private, where a lot of care is taking place. She has got an example, but I'll let you come back first and then see how we go with the response.
Well, it's interesting that you say, because we found that some of the early adopters, or as Robyn likes to say, you go where the energy is. There is a lot of energy in emergency departments. So I think there's probably some truth to that. And perhaps because there are some shorter term outcomes that can be quantified and measured. And then I guess it comes back to the point about what are you measuring in terms of outcome? Are you just measuring a reduced utilisation of a service? Well, that's certainly an intermediate measure, and we're interested in doing that. And we can say that according to the definition, the Choosing Wisely definition, it shouldn't have occurred. So if it doesn't, then that's a good thing. But actually, are we more interested in patient outcomes as a result of them not receiving that intervention? And that's probably the gold standard, but much harder to get to. So I think there's actually enough evaluation to be done across the board, and I think there is a lot of scope in outpatients. But the fact that we've had a lot of early uptake from probably primary care and ED would indicate that they see some real opportunities for evaluation there in those environments.
And I suppose going back to the early discussion around that whole take-up, you sort of touched on that, where you when you're doing these sorts of things, which goes back to Jill's point about the implementation science, you really do have to go where people are wanting to do something to get that momentum and get that build momentum to get this broader. You know, there's no point flagging a dead horse, as to say, it's, you know, flogging a dead horse. So you really do need to go where the energy is and people are interested if it's led by that group, don't you?
Absolutely, and the whole structure for Choosing Wisely is very much based on a social movement. So it's intended to be maximally inclusive, minimal rules, and so that's where you want to encourage people who come in of their own volition. But it means you also have to give up a little bit of control too, which goes back to your question about the lists as well. So it's sort of that sort of balance, but it's definitely not trying to shove things down people's throats who aren't willing to receive it.
Just changing pace a little bit, a question I had, and it was as you were going through just introducing Robyn, and I just wondered about the information. There seemed quite a bit of information, and just thinking, say, if you took general practice, and having worked with general practitioners who will tell you how busy they are and how difficult it can be to just wade through some of that sort of information. How quick and easy is it, and is that a barrier to implementation if you know, GPs, clinicians can access this information readily, and they may be able to, but it did seem there's quite a lot of information there to have a look at whilst you might be live doing a consultation?
Yeah, but that's the ongoing challenge for GPs about how they access this stuff quickly. We're talking to, so as an example, we're having some discussions with groups like Health Pathways, for example, about how we can embed some of these recommendations in those systems. And so the idea is to look at how do we make this information that is accessible in as many locations as possible that doctors but also consumers might be going to find it, but totally accept that is a challenge in terms of their time poor and how do they find it.
Yeah, and I was thinking of the health pathways in particular as being a resource that, you know, the couple of clicks to that information could be a shortcut, and obviously you're across that, which is absolutely
yeah.
brilliant.
We're piloting that at the moment, and it would be great if there are people who have connections with other health pathways. We're working with a group in Sydney, but if other people have interest, we'd be very happy to talk to them about that as well. I'm
linked with the evaluation group around health pathways, so I'm happy to feed that through into a number of PHMs.
Great.
So that's an aside, so we'll carry on with your presentation. But the other bit is not just health pathways, would be the patient-centred medical homes. And as that's a big government initiative, I just wondered what if you've got any push in terms of integrating something like this into that concept.
We haven't actively progressed that at this point, but certainly, again, that's one of the opportunities that we would be interested to explore, and that's why it's great having these conversations, because there's obviously so many things that we could do. So that's actually a great suggestion that I'd be happy to explore.
Yep, excellent. Okay, we have another question. This one for you, Adam. You said choosing wisely recommendations are feeding directly into the MBS review. Can you provide some more detail, e.g. has choosing wisely recommendation been cut from the MBS? And do you think the feeding into the MBS process means that cutting an item from the MBS is more acceptable?
So
do you want to go through that again, or are you okay?
Yeah, so I'll tell you just very briefly about the process. I guess that's important from a start. So within the MBS, so the task force which I sit on, underneath that we have a whole series of clinical committees, and there's 10 or 12 members per clinical committee. As you can imagine, they're specialty oriented, and it's really down to that clinical committee to again, a little bit like the choosing wisely process, to think about areas within their own clinical domain that are problematic on the MBS for any number of reasons, low value care being one of many. But to sort of help prime them or prompt them to think about it, we actually encourage them to look at the choosing wisely recommendations. And in fact, some of the people who are sitting on the clinical committees are also sitting on the choosing wisely development committees for their society or their college. So there's that cross collaboration that's happening naturally anyway, but otherwise it's just a feeder mechanism, as is the Atlas of Healthcare Variation, as I mentioned as well. They're all just multi-pronged ways of prompting these committees to think about where there might be some lower hanging fruit potentially. And yes, I do think it's going to add to the legitimacy of the process, because again, this is a very, very heavily clinician-driven exercise, both choosing wisely and the MBS review, and the clinical committees are really the ones who are navigating those individual clinical areas. The only thing I'll pick up on about the question, and I don't think it was intended to be framed this way, but it was about things being removed. There's actually very few things that are going to be removed from the MBS. Some have already, but most things there's going to be a refinement, much that you saw with the vitamin D example. It's about better targeting the patient groups that we know are going to benefit, and trying to avoid service utilisation on those groups that are not going to be benefit or potentially going to be harmed by it. So it's a nuanced refinement question. And if you're interested, there's just been only 2 weeks ago, we released our clinical consultation, or our community consultation, for the latest round of clinical committee reports, and they're available on the MBS Review Task Force website.
So what I'm hearing then, it's more about effective targeting, isn't it, in a sense?
Yeah.
About resource utilisation, and not really a stick as in you can't have payment, but actually can we work more collaborative with you around the evidence base?
Absolutely. So what are the clinical characteristics? What are the patient characteristics that most lend to effective outcomes? What's an appropriate timing or an interval for a test? Simple things like that, as you can see with vitamin D, can have a very big impact. Should everyone be allowed to have 10 vitamin D tests a year, or is probably 1 enough or 2 enough? Things like that.
Yeah, and I suppose on that as well, when we talk about patients and that patient perception, or there's a perception from general practice that there is some pressure from patients. Is there any work done with the media to communicate that back out? So when we do make such savings, which do you communicate that out in terms of back to consumers and to clinicians, I suppose, as well? So with the example. Yeah,
so on the MBS review, it's too early. I guess the reason that you haven't heard more about the vitamin D outcomes and the like is probably because there was a change of government, so a change of focus, and it's up to people like me to suggest that there have been these considerable success stories very recently within the Australian environment. But I think as the MBS review progresses effectively, I think we'll start to hear more and more of these successful outcomes.
I suppose that touched on the other bit around how to keep the momentum going, and how we are caught up often with political cycles and different political ideologies, and it's keeping that momentum going and the implementation going through different cycles of government, which is always a challenge for any policy or guideline, really.
Absolutely, and look, that is one thing that I really couldn't stress enough to this audience, is that, you know, not that long ago, when you talked about this issue, very quickly it turned to rationing and taking things away. It's changed dramatically. In fact, it's done a 180. In fact, now you're almost on the fringe if you're not talking about appropriateness, whereas it used to be the other way around. And some of the more successful campaigns, including one out of Ontario, I attribute much of the success of those processes to there being strong political will. So a health minister who's willing to stand up and say this is safety and quality, it's not about dollars, and have clinician, have research, have policy communities behind those ministers backing them all the way, is only going to improve, you know, the snowball effect. So they need to feel supported in this process as well at a political level.
Yeah, and I suppose getting the language right is really important. So you pointed out around getting the clinical language right. So the narrative, it's not about rationing, it's about quality and safety,
right,
which may lead to resource you know, efficiency, but it's not driven by efficiency, it's driven by effectiveness and quality and safety. Okay, I don't know if we've got any more questions, but just before we do finish, I'd just like to ask about the research. Obviously, one of our interests is around the research, and where you think the next steps are in the research, especially around, you know, how do we know if this is, one, been successful in terms of take up, but also the outcomes and impact?
Look, well, I guess we're looking at, when I say we, so MPS Medicine-wise, I guess part of our role is looking at how we can actually gather data to show that we're having an impact. And so we're looking at that at multiple levels. So some of it will be, as I've talked about, kind of where we run an intervention and looking at the impacts of that at a national level. Looking at pilot sites, so demonstrating models of how you can successfully implement programs and have an impact. But also more beyond that, where is there evidence too of this thinking about unnecessary and low value care being kind of built into the business as usual sort of activities. So how can we demonstrate those sort of activities are actually happening, because they're the measures of success. So they're the sorts of things that we're looking at gathering, as well as also continuing to survey clinicians and consumers about their knowledge and attitudes around unnecessary care, and looking at how that changes over time as well. So I guess that's sort of a spectrum of the different types of measures that we want to look at to show that we're having an impact. And that's why this audience is really important, because we can't look at all of it. So obviously MPS is looking at some of that. People like Adam, who have fantastic research programs, are looking at large numbers of things, but no one sort of individual can look at all of it. And I think we have to be clever in terms of thinking about what we look at too, because it's not sort of a traditional kind of program. Like I mentioned earlier about, I'm really interested in the idea about how you demonstrate impact on policy. And I think there are a number of different ways that we could do that, but I think that's a really interesting question to be exploring. How do we sort of set the foundations for assessing that type of impact?
And I would just add that we almost have a nice problem at the moment, in the sense that there is a lot of confounding in this space, because it's not just choosing wisely. Because there's been such a movement and there's such a growing consciousness out there, we're already in the data seeing some dropping off in utilisation of practices considered to be lower value. It's hard to actually attribute any effect to one intervention, to one campaign, because there's so much happening. That's a good thing, but it's going to be difficult for us to parse out where individual points of influence have occurred. So it's going to be a challenge, but a nice challenge for us to have. And the only thing I'll add is that we focus a lot today on the overuse of low value care, but there's an opposite end of the spectrum, and that is the underuse of high value care. And certainly within the MBS review, we're as focused on that as we are on the low value care, knowing that some people are not receiving care that they ought to, and some people are receiving care that they may not necessarily need. So it's about balancing that back to the middle. So one evaluation element that I'm interested in is looking at the two tails of that spectrum, trying to see whether we're getting that balance right.
And Susanna, we'll just flag that in terms of impact, so we are in the process of finalising a report that's based on the first 12 months of the Choosing Wisely initiative. So obviously within the first 12 months, you don't expect to see dramatic changes, but that will be the forum where we publish some of the outcomes from both our consumer and health professional survey work. So I encourage you, people who are interested to find out about that when it comes out, to go to the Choosing Wisely website and sign up for the newsletter, and then you'll be able to receive that when that comes out.
Yeah, so we want Australia-wide collaboration, but we also want that sort of micro-level collaboration. So if you're in Perth, if you're in Adelaide, you know, hook up with your local clinical groups, policy groups who are doing work, and get some good, robust intervention plans in place, as well as evaluation plans. That would be the, and then share them at a national and international level. I think that would be.
Yeah, and I mean, we're doing some work in WA, and as you know, I'm trying to link in with you guys as well. There was an interesting comment raised by Jill Harvey, who says it sounds like there is really a strong need for parallel process evaluation, given the influence of local and national context. I think that's where you're getting at. The health pathways have got that sort of international, if we say Australia and New Zealand, we do budget as international, and we have different countries, but we've got that evaluation team where we are actually sharing that evaluation work and some of the methodologies and sort of logic models that people are using. And I think it's a good model, and that's what I hear you encouraging, really, that we collaborate on this so we can share best practice around research and evaluation. The other thing I'd say on that, which I think you'll do really well, is about making sure we get that evaluation in as soon as possible. Because you know, you can't go back and catch a baseline. You can only get baseline once. So if you come in at the end and it's not been caught, it's a retrospective fit. So I think there is something in trying to get that message out to the health industry, really.
Yeah, absolutely. I'm very happy to talk with yourself or anyone who's online more about, you know, how we can do that really effectively.
Sorry, somebody's asked me a question and says, can I see their question? So I'll just go and have a look. I'm flicking between different questions places. Okay, a couple of questions come through on the other question board. Just let me put it up. The different medical colleagues and indeed different specialty clinician groups within each may be taking somewhat different approaches to how they decide whether something is evidence-based. Okay, so the different perspectives may take different approaches to deciding whether something is evidence-based, which could itself be a source of unwarranted variation. Has Choosing Wisely considered what, if any, role it could play in addressing this in order to support greater consistency in the process of decision making nationally? Does that make sense? Oh, again.
Yeah, look, it's a good question. Again, I guess this is where when the colleges sign up to and societies sign up to participate, we provide some guidance around that. We ask them to provide recommendations that are within their area of remit or of a reasonable volume or cost, so that they're not picking sort of really random, obscure things, the things that are done reasonably frequently, and that they look at the evidence that's associated with that. But intentionally, we don't provide a whole lot more kind of structure and rules around that, because again, coming back to my comment earlier about this is, in essence, it's a campaign, and it's structured like a social movement. It's not structured like a guideline development group. So the development of the list and the colleges choosing how they approach it and engaging with one another in the conversation is as important as the lists themselves. So if we start to apply very strict structure to how people develop the lists, it will cease to be as inclusive as it currently is, because the reality is some of the organisations who've signed up have very limited resources, and that would be a barrier for them to be getting involved. So it's really important that the recommendations are evidence-based, but we certainly don't want to go down the track of having this become something that's so structured that it becomes much more like a guideline development opportunity. We are talking to groups, for example, like Therapeutic Guidelines and a number of organisations around how the Choosing Wisely recommendations might then be something that's considered in terms of guideline updates and new guideline development. And that's where then you would have that particular rigour around the evidence that supports them happening, and they can apply all the processes that they normally do.
As someone who's from a health technology assessment background, it's very seductive to think that this process become some meta HTA process, but as Robyn indicates, that's just not feasible for many of these colleges. And we know that in the United States, the American College of Emergency Physicians model was heralded as the gold standard model, if you like, in terms of the degree of rigour that was included around that process. And we've certainly put that forward in Australia to the various groups, and I know that the Evolve program has done the same, but it would be unrealistic to be too directive about that. And the other thing that, just to reiterate Robyn's point, is that some individual practices within a specialty area might seem like they should be, you know, #1 priority area. Some groups very consciously decided that they really only want to focus on something that the doctor, the individual doctor in the clinical encounter, had control over influencing. And if they didn't have control in that individual encounter, then they didn't include it on the list. I actually think there's something to that that's quite reasonable, and there's a bit of face validity to that, because it's clinician driven and they want clinicians to feel like they have some level of control over whether or not they can influence that practice. Whereas things that I'm interested in that we might control at a sort of higher policy level may not have necessarily come in under the purview of some of these lists.
Excellent, thank you. I think that's all from the questions. I just wondered if you've got any other last thoughts or observations you'd like to make, having just, you know, delivered the presentations and then gone through a series of questions.
Thank you for participating.
Yes. Yeah,
okay.
And I'd like to just do one plug too, coming up.
This is your chance, go for it, Robyn.
Yeah, no, this is so early next year, this is in development, but we're anticipating probably around March or April next year, we're intending to hold a forum that's dedicated to exploring, you know, what's happening in the implementation space around choosing wisely. So again, I really encourage people to get in touch with us, sign up for the newsletter, but I'm also happy for people to contact me directly if they'd like to know more about that as that develops.
And we'd happily, I'm sure, I'm speaking on behalf of the role we of the committee, but I'm sure that the association would be happy to advertise that event for you as well. So that gets
fantastic, that would be great.
Okay, thanks then to both of you for a very engaging and insightful presentation. I really enjoyed it, which is always a good gauge if the chairs happily with the presentation, as I can't see any other faces but yours. And we'll watch with interest as the Choosing Wisely campaign builds further momentum. I think it will, given the current climate we're currently operating in. Before everyone does go off, I'd just like to draw their attention to Sarah's announcements around the next webinar, which is on October 19th, and also the National Press Club event, which will be held in Canberra on the 1st of December. If you want any further details, please join us and have a look on the website. And also, if you are interested in joining the association, it's a fun and exciting group to be involved in, then again, please go back to our website. And before I finish, and before we go off, a final thanks to Sarah Green, who organises these webinars, and she takes all the stress around whether or not they work, so we just all pitch up. To our speakers again, thank you, Adam and Robyn. It was really great and really enjoyable. And of course to our audience for their interest in some great questions. I think you'll agree, speakers, that we had some great questions from the floor. And to everyone, just to enjoy the rest of the day, and I hope to see you at one of our events really soon. Thank you.
Thank you.
Thanks.
Thanks. Bye bye.
Bye bye. Thanks, Suzanne.